Hello, my name is Maxine. I'll be your tutor. Welcome to Cardiology Basics, Anatomy and Physiology. This is a free module and I hope you enjoy the presentation. Our teaching philosophy at Cardiorhythms is very simple. Although our seminars are intensive, they are also very relaxed. Clinical case studies are of utmost importance in this teaching method. It fosters a more hands-on approach whereby each student can effectively practice what they have just learnt in theory. The emphasis is then that the student internalises the information rather than simply memorising facts. Our goal here is then that the student is motivated and will want to continue in their studies. We believe there is no such thing as a bad student. Teachers work for their students, and we are committed to making your online learning experience as rewarding as possible. For those of you who are new to cardiology, you will probably already know that an ECG is a tracing of the heart. Maybe some of you already know that it's an electrical tracing, but are confused by what this actually means. Before we can understand exactly how an ECG works and what it can tell us, it's vital to understand some basic cardiac anatomy and physiology, and to understand the electrical conduction system. By the end of this module, you will know what the main structures are, and how the heart functions, both mechanically and electrically. I always think of the heart as having three main regions of interest. These can be represented by three main types of cardiology investigations: an echocardiogram, or echo for short, a coronary angiogram, and an electrocardiogram, or ECG for short. Click on each of these investigations to find out more. An echocardiogram is a cardiac ultrasound examination which gives us information about the structure and function of the heart. The structures include the heart muscle, the heart chambers, and the heart valves. Because the image is moving, we can also assess heart function. For example, how well the ventricles are contracting or how well the valves are opening. A complete examination of the coronary artery system requires an invasive procedure known as an angiogram. The coronary arteries are the vessels which supply the heart muscle with oxygenated blood, and if they become blocked, this can lead to a heart attack. They are not visible on ultrasound. Instead, a cardiac catheter is introduced into the aorta and the patient is x-rayed while a radiocontrast agent or dye is injected into each of the coronary arteries. This investigation is the main diagnostic tool for assessing coronary artery stenosis or occlusion. Here we have a diagram of the electrical conduction system. This is the power supply, if you like, which flows within the structure. This is not visible to the naked eye, and nor is it visible on ultrasound or an angio, and thus we assess the electrical system by means of an ECG. This investigation is the main tool for assessing electrical abnormalities. Here we have a very basic diagram outlining the main structure of the heart. Note that it has four chambers. There are two atria, also known as the collecting chambers, and two ventricles, also known as the pumping chambers. However, I think it's better to think of the heart as having a left side and a right side, each with an atrium and ventricle. The left and right heart is separated by the septum, and this is very important because it prevents oxygenated and deoxygenated blood from mixing. The heart actually has four valves, but in this view we see only two of them, the mitral valve and the tricuspid valve. Cardiac muscle cells, the myocardium, performs the mechanical work of contraction, the pumping action. Of course, this is only a 2D illustration. In reality, the ventricles are normally larger than the atria, and the left ventricle is normally larger than the right ventricle, quite simply because it has to work harder. You will also note that in most diagrams the left heart is displayed on the right, and vice versa, just as if you were looking at a person straight on. We commonly assess structure and function by means of an echocardiogram, which is an ultrasound of the heart. Let's take a more realistic look at the illustration on the previous slide as it's presented on an echo. This is a 4-chamber apical view of the heart. Now don't panic, we like to complicate things in cardiology. The atria are displayed at the bottom of the screen, furthest away from the transducer, and the ventricles are at the top. However, we know that normally the ventricles are larger than the atria and that the left ventricle is larger than the right ventricle, so we shouldn't have too many problems identifying the main structures. So here we have the left ventricle, the right ventricle, the left atrium, and the right atrium. Here we have the septum, the mitral valve, and finally the tricuspid valve. Here we have a slightly more detailed illustration to include the main vessels of the heart. These bring oxygenated blood, represented by the red colour, and deoxygenated blood, represented by the blue colour, in and out of the heart. Let's have a look at this in more detail. The right atrium receives deoxygenated blood from the body via the superior and inferior vena cava. The superior vena cava delivers blood from the upper half of the body. Therefore, as you'd expect, the inferior vena cava delivers blood from the lower half of the body. At the same time, the left atrium receives oxygenated blood from the lungs via the pulmonary veins. In this illustration we can see only 2 pulmonary veins, but there are usually 4, 2 from each lung. However, this number can vary normally between 3 and 5 openings, depending on their formation. To also confuse matters, as veins they carry oxygenated blood, other veins in the body carry deoxygenated blood. Blood from both atria travel to the ventricles through the tricuspid and mitral valves. The right ventricle then pumps deoxygenated blood into the lungs for oxygenation via the pulmonary artery. Again, just to confuse matters, this is the only artery in the body that carries deoxygenated blood. At the same time, the left ventricle pumps oxygenated blood into the aorta and out to the rest of the body. Going back to our 4-chamber view of the heart, let's assess the sequence of contraction in more detail. So what have we learnt so far? Well, we know that the right heart pumps deoxygenated blood to the lungs, and at the same time the left heart pumps oxygenated blood to the body. When the atria are filled with blood, as shown here, the mitral and tricuspid valves open. However, it's a common misconception that the atria actively pump blood into the ventricles. In actual fact, most of this, approximately 80%, is achieved passively. When the ventricles are almost full, the atria then contract, and this is known as the atrial kick. This pushes the remaining 20% into the ventricles. Overfilling and stretching the ventricular muscle in this way maximizes ventricular function. Therefore, atrial contraction must occur before ventricular contraction. This is known as sequential contraction. Electrical activity is coordinated to ensure sequential contraction. In other words, in a normally functioning heart, the conduction system ensures that the atria contract before the ventricles. However, these specialized cells not only coordinate the electrical activity, they also initiate and propagate the electrical impulses to stimulate the cardiac muscle cells. In simpler terms, this means that the heart contracts in the right place at the right time. The electrical system in this diagram is outlined in the colour blue. Please bear in mind that this is just a simplified 2D illustration. Let's put some markers on the main components. Hover over the marker and you will be given the name of the structure, or alternatively, click a marker for more information. If you are new to the conduction system, follow the numbers in order. The Sinoatrial Node, or SA node for short, is located on the wall of the right atrium, near the entrance of the superior vena cava. All cardiac cells can spontaneously generate electrical impulses without an external stimulus, and this is known as automaticity. The SA node normally initiates the electrical impulse because it has the most automaticity. In simpler terms, this means that the SA node generates impulses faster than any other area of the heart. Due to this fact, the SA node is known as the primary pacemaker. This is not to be confused with an artificial pacemaker. The SA node naturally discharges at approximately 60 to 100 beats per minute. However, innervation of the sinus node is provided by the sympathetic autonomic nervous system, which if stimulated can speed up the rate, and by the parasympathetic system, which in turn can slow the rate. Click here to go back to the main slide. After leaving the SA node, the impulse is transmitted via various pathways through the atria and to the Atrioventricular Node, or AV node for short. Electrical activation of the atrial muscle cells, also known as depolarization, leads to atrial contraction. The AV node is very special because normally it's the only gateway between the atria and ventricles. There are exceptions to this rule, but this is something we'll be looking at in other modules. The AV node has three special roles. Number 1. It slows down or delays the impulse to allow the atria to finish contracting so that overfilling of the ventricles can occur. And, as we know, this is important to allow for maximum ventricular contraction. Number 2. The delaying of the electrical impulse can serve as a protective mechanism in that it protects the ventricles from excessively fast atrial arrhythmias. And finally, number 3. In the event that the SA node fails, the AV node can also take over as a secondary or latent pacemaker, discharging at around 40 to 60 beats per minute. Click here to go back to the main slide. After leaving the AV node, the impulse travels down the bundle of His. Named after a Swiss cardiologist and also known as the Atrioventricular Bundle, the His bundle is the route of communication between atria and ventricles. It starts at the AV node and passes through a fibrous layer which separates the atria from the ventricles. The bundle of His then splits into the right and left bundle branches. Click here to go back to the main slide. The right bundle branch, as you would expect, spreads the impulse to the right ventricle. At the same time, the impulse then travels down the left bundle and its associated fascicles. The dividing of the electrical impulse down both right and left bundle branches ensures that both ventricles contract simultaneously. Click here to go back to the main slide. The left bundle branch initially spreads the electrical impulse to the upper segment of the ventricular septum, before dividing into a further two branches or fascicles. Why does the left ventricle have more fascicles than the right? Well, quite simply because the left ventricle is larger than the right ventricle and needs more branches to spread the impulse quickly through the bigger chamber, so that it contracts simultaneously with the right ventricle. Click here to go back to the main slide. The left anterior fascicle delivers the impulse to the anterior and superior regions of the left ventricle. In other words, it's directed toward the front and the top of the heart. If you were looking at a person straight on, imagine that arrow directed toward you. The left posterior fascicle delivers the impulse to the posterior and inferior regions of the left ventricle, which is the back and the underneath of the heart. In diagrams such as these, you will see these fascicles labelled either way. It's not really that important in a 2D diagram, as long as you know which regions go with each fascicle. I just personally find it easier to illustrate it this way in my teaching. Click here to go back to the main slide. Once the impulse has been propagated through the right and left bundle branches and fascicles, it reaches and spreads through the Purkinje system. The Purkinje fibres are located in the inner ventricular walls, just below the endocardium. This causes depolarization, electrical activation, of the ventricular muscle cells, which in turn leads to ventricular contraction. As mentioned before, all cardiac cells have automaticity. In the event that the primary SA node or secondary AV node pacemakers are not functioning correctly, the Purkinje fibres do have the ability to act as a latent pacemaker and can create or discharge an electrical impulse at approximately 15 to 40 beats per minute if left to their own devices. Thus, they can serve as a last resort if all other pacemakers fail. If you have followed the numbers in correct order, well done, you have reached the end of this section. Click the button below to go back to the main slide. You can review the various components again as many times as you want. Alternatively, proceed to the next slide. So let's review the conduction system again. Normally, the electrical impulse is initiated at the SA node. It travels through the atria, which ultimately results in atrial contraction. The impulse then ends up at the AV node, the gateway between atria and ventricles, and is delayed slightly. It travels down the bundle of His, and then simultaneously down the right and left bundle branches, the latter dividing into the anterior and posterior fascicles. The impulse then finally ends up in the Purkinje system, resulting in ventricular contraction. Test your knowledge and have a go at the following interactive exercises. Don't worry, your marks are not logged anywhere and you can try as many times as you like. Good luck! Have a go at the drag and drop quiz to test your knowledge of heart structure. I've started you off with the right atrium. Just drag the label to the correct part of the heart. Once correct, the label will change colour. Drag and drop the labels into the correct places. Once correct, the label will change colour. You have reached the end of this free module, and we very much hope you've enjoyed the presentation. We have much more free stuff available on our website, and if you have any questions, please do not hesitate to contact the team. Alternatively, you can post any comments or questions on our blog or any of our social media outlets. If you have the time, please complete the survey on the next slide. Thanks for listening and keep in touch.